Well, hello everybody, and this is a talk for 1 p.m. The talk is on psychiatric observation and treatment units. We're being recorded, so I wanted to start on time. And so we'll go ahead and start right away. Got about 180 minutes worth of material that we're going to try to squeeze into 20 minutes, so I'm going to get started and get going right away. So basically we're talking about a concept that has been forwarded that has been proven to dramatically reduce psychiatric patient boarding in emergency departments around the United States. In fact, eliminating boarding in some of the sites that we've worked with. So psych obs units are basically just setting up separate psychiatric ERs that are adjacent or contained within the emergency department or very close by, sometimes on the same hospital campus. The outcomes and the metrics have been tremendous and extremely cost effective and make a lot of sense. And let me explain them to you real quickly. So psychiatric emergencies are actually defined by EMTALA as medical emergencies, and they are required to be medically screened, evaluated, and attempts to stabilize or else admission, just like any other emergency medical condition. Pretty much those psychiatric emergencies in the definition of psych emergencies are when a patient is considered, due to their psychiatric condition, to be dangerous to themselves, dangerous to others, or so impaired by their psychiatric condition they're unable to care for themselves. And you could probably stretch that into the idea that if somebody is at risk to evolve into dangerousness or inability to care for themselves, you could probably say that that's an emergency as well. So what's been happening in the last 10, 15, 20 years is that there's been an enormous uptick in the number of psychiatric patients with emergency conditions coming to general emergency departments in the USA. And this has led to some really unfortunate metrics. People who have a psychiatric emergency, traditionally, unfortunately, the main way that they've been getting care is if you come to an emergency department with a psychiatric emergency, there's this kind of default treatment, well, we need to find you a psych bed because we really don't have anything else available for you here, which in and itself, and I'll get into that in a second, is not the way we deal with any other medical emergency. And so it's not surprising that some of these numbers and metrics have come about as the number of psychiatric emergencies have increased. If we were just feeling like, well, the default treatment is find them a bed, pretty soon you're going to run out of beds. If we were, our default treatment for chest pain was to admit everybody to the med-surg floors, we'd be talking right now about this massive shortage of hospital beds in America. You can't just assume that the appropriate treatment for everybody is to hospitalize and that there's going to be an infinite number of beds to always help these folks, no matter how many keep coming in. So we've had this dramatic increase in psych patients coming in, and we really haven't changed the rubric. So what's happened? Patients waiting for these psych beds are waiting 3 times as long for any other admits in the ED. ED staff are spending a lot of time faxing and making phone calls and doing all kinds of things to get these inpatient beds. And meanwhile, these patients are boarding sometimes, for many, many hours, sometimes for days, and every hour they're there is costing that emergency department at least $100 on top of everything else that their visit is costing them. So what is psychiatric patient boarding? It's essentially patients who are in a medical emergency department and they're just waiting there for a psychiatric eval or a psychiatric disposition. So often these folks are kept in holding rooms with sitters, they're kept with security guards. Sometimes they're just strapped to a gurney and put in the back hallway of the emergency department, and sometimes without any treatment, sometimes maybe with heavy sedation, but rarely with any kind of targeted treatment for their psychiatric symptoms. Why has this become a big deal, and why is there such an overflow? Because there's been a 55% increase in psych patients coming to emergency departments in the past 10 years. The really stunning fact is that over 400% increase in emergency department suicidality patients in the last decade.
Well as on.
Yeah? Yeah, that was weird. It was like ghosts. Boarding's being a big problem. There's a lot of people studying it across the country. Personally, I'm involved in about 4 different national committees about this issue right now. But different studies have shown that the average patient who's boarding for psych reasons in EDs in the USA is between 8 and 34 hours. Even places like Harvard, Mass General have 11 to 15-hour stays. Where I did most of my research in California, I started my research work after I saw that a 2012 California Hospital Association study said that of all the 575 hospitals in California, the average wait was over 10 hours for a psych patient seeking psychiatric transfer. So it's a very costly practice. It's obviously very difficult for patients, and it's costly to them in humane terms, but in terms of just thinking about what it's costing the hospital or the emergency department or the staff there, average patient who's boarding in an emergency department, it costs that hospital over $2,200. And that's actually an 8-year-old number, so it's probably much higher than that now. And what's even worse is that these symptoms of these patients, since they're so often not treated and the ED is not an optimal location for people with psychiatric emergencies to be housed, their symptoms often get worse, they escalate. That's when you get bad things like agitation, assaults, violence, aggression, and those are all things we just as soon avoid. So what have been suggestions to resolve this boarding situation? As I was mentioning a second ago, far too often the default treatment for psych patients coming to emergency departments is, let's find you an inpatient psych bed. And we don't do that for any other emergency medical condition. And if we change that rubric, if we change that mindset to actually think about maybe we should be treating these people at an emergency level of care and see what that would happen. Because, if you come in with chest pain, as I mentioned a minute ago, we don't admit everybody with chest pain. We try to assess and treat and stabilize chest pain in the emergency department. Only 10 to 20% of chest pain patients end up getting admitted. Interestingly enough, it's about the same for psychiatric emergency patients. If you get them into an appropriate location with appropriate personnel, start evaluation and treatment right away, you're going to end up 80% plus of psych patients can actually go home or go back to the community in less than 24 hours. So there's no reason to admit them any more than you'd be admitting chest pain patients. And so what we've been doing has been wrong, which is saying, the way we solve the boarding situation is we need to build more inpatient psych beds. A, nobody wants to do that, and B, that's probably not the best way to solve this. Maybe it would make a lot more sense if we started treating these patients at the emergency level of care and then reserve those inpatient psych beds just for those patients who truly had no alternative. Again, remember that federal EMTALA laws say that psych emergencies are medical emergencies. And something that we talk to hospitals a lot about is that you can't just keep thinking that if we keep kicking this can down the road that these psych emergencies are going to go away or somebody's going to magically have them disappear. It's really time for hospitals to step up and recognize that 1 in every 8 patients coming to emergency departments now is there for what we call behavioral health reasons, substance abuse, or psychiatric reasons. And assuming they're just going to go away or that we don't need to learn more about it is the same thing as saying, like, well, we don't need to learn about asthma or cardiology or sepsis, because it's basically the same percentage of patients that are coming into emergency departments. So how do we actually, what's a better way to treat emergency psychiatric patients, and what's our ways of thinking about it? We published what's basically the core 6 tenets of emergency psychiatric care, and I could spend 2 hours talking about each part of this, but just real quickly, since I have a very, very short period of time here, ideas basically are that first, when somebody comes to a hospital with what appears to be an emergency psychiatric condition, we need to do a good medical screening exam. It doesn't have to be comprehensive. Labs aren't necessary, but you need a good once-over. You need vitals. You can't just say, oh, this person's psych, and send them to a therapist or a social worker. Why is that a big deal? Because anywhere from 10 to 25% of what appears to be psychiatric emergencies are either symptoms of a medical emergency or they're a psychiatric emergency that's being exacerbated by medical conditions. So until we actually take care of those medical conditions, we're not going to be able to really work on those psychiatric emergencies, and some of those medical emergencies can be life-threatening. We have patients who come in with really low blood glucose, and it looks like they're having a schizophrenia exacerbation. Somebody who's got head trauma and maybe have an intracranial bleed, that can look like a psychiatric condition. And if it's not obvious, maybe you got somebody with a hat or a lot of hair and you don't see that they had head trauma, you could miss that. I have plenty of case studies of patients who passed away because everybody thought it was just psych and ended up sitting in a chair in a waiting room. So it's really important to do that. Once we make sure the person is medically appropriate, the way we look at it is let's eliminate all non-psychiatric emergency medical conditions. And then let's have the psychiatric emergency medical condition become the focus of treatment. Once we do that, we want to rapidly stabilize that emergency medical psychiatric condition. Why is that a big deal? Well, historically, when people come in and to an ED and they're triaged, psych gets the last seat in the row, because it's not real obvious what's going on, and it may not seem like it's that big a deal. Because we got somebody who's been in a car accident, and somebody's actively bleeding, and somebody who's got crushing chest pain, and all these other kind of things that are going on that seem much, much more important. But recognize that the people with psychiatric emergencies are really, really suffering as well, and the longer we delay things, the worse things get, and the worse the outcomes tend to be. I mean, what does it feel like to be so suicidal that you don't want to take another breath in the world? I don't think we know what it feels like, but that must be just as bad as most kinds of pain. How about literally hearing voices in your head, because that part of the brain lights up just like if you were hearing me right now, if we lit up your brain with a PET scan. The psychiatric part lights up with schizophrenia patients who are hearing voices. What if that's telling you to kill your friends and your family and you don't want to do that? What kind of agony, what kind of suffering must that be? So we want to resolve that, because these people are experiencing the psychiatric equivalent of pain, and shouldn't be thought of as like really low acuity in back row. Actually, they're very high acuity, and the more we push them to the back, the higher the risk is of self-mutilation or aggression, violence, and trying to hurt others. The next three things go hand in hand. We want to avoid coercion. Traditionally, a lot of psychiatric emergency care has been sit down and shut up, or we're getting security. We find that the more we try to engage patients in what we call a therapeutic alliance, much less bad outcomes, much less assaults, much less staff injuries, patient-to-staff assaults, patient-to-staff injuries. Just by changing the dynamic, by instead of like, hey, what's your problem, psych patient, sit down and shut up, to, hey, it looks like you're going through a tough time, we're going to get you through this. Just relax and everything's going to be okay. And one of the biggest differences that I think in the traditional way of looking at working with these psych patients is we want to do something called treat in the least restrictive setting. And that's a real change from the idea that the best thing we can do for somebody having a psych emergency is to find them an inpatient psych bed to transfer them to. If you just think about it in terms of yourself, would you want to be hospitalized if you didn't have to be? Do you want to, especially a psych hospital, which is locked and very regimented, maybe that's not the best outcome. Maybe a better outcome would be if we could find a way to stabilize within a few hours and avoid hospitalization so that they could be in the least restrictive setting, which is maybe home, being able to come and go as they please. Wouldn't that be a better situation for most of us, and indeed for our psychiatric patients as well? And then the other thing that we want to do is we find that the best way to reduce the number of people coming to ERs with the psychiatric emergency is not to try to prevent them from coming in the first place, or look at ways to siphon them off, or say like, oh, here's a program to keep you from coming to the ER. When you've got an emergency, it's unpredictable, it's severe, it's debilitating, it's stressful, it's agonizing. We want to get people that emergency care as quickly as possible. The best way to minimize psychiatric emergencies is once we've treated that emergency condition, let's do such a great job in reconnecting them, or initially connecting them to outpatient mental health services, that they don't end up in an emergency situation again, and we're able to get them a really solid follow-up, get them on their meds, and we treat them in such a way in the emergency department that they see us as colleagues rather than adversaries. And when we do that, the long-term outcomes for the patients are going to be incredibly much better, and they're probably not going to get into emergency situations as much often. So dedicated emergency psych facilities or psychiatric OBS units, hospital ground units. These are not community-based drop-in counseling centers. We're talking about EMTALA compliant emergency department levels of care, but they're specifically for psych units, psych patients. And this is not that unusual concept, because we think of burn units, we think of high-risk pediatric units, we think of obstetrics. Everybody goes in emergency situations to different specialized units. It's not that big of a difference. We can do this for emergency psych patients as well, and we've done it actually at scores of places around the USA and other countries too. The main models that are operating for emergency psychiatry and psych OBS units in the USA, they're called PS, CPEP, CSU, psych OBS units. The more modern unit is called an Empath unit, and I'm going to get into that a bit more, because that's really where the industry has been heading. The names, what they mean: crisis stabilization unit. A lot of people like to use that for their psych OBS, but really that's traditionally more means a drop-in counseling crisis respite center that's in a community. A PS or CPEP is these high acuity units that you find really in urban centers, usually affiliated with safety net hospitals. Empath units, as I said, newer ones that can be in any size or shape of hospital, and they're really just an extension of the emergency department specifically for psychiatric patients. They can be moved there quickly from the emergency department once they've otherwise been medically cleared, and they have some really tremendous responses. So Empath stands for Emergency Psychiatric Assessment, Treatment, and Healing Unit. And as I said, they're basically these high acuity psychiatric patients, emergency department. They're designated destinations. So it's not like you go into the ED and somebody sees you and determines, okay, you go to inpatient, you go home, you go to the Empath unit. No, as soon as you're medically clear in the ED, everybody moves out immediately into the Empath unit. That's where the assessment is. That's where the determination of what happens next happens. And what's nice about that from the emergency department point of view is all you have to do is a really brief medical clearance. Sometimes that can be done in RME or a triage, just if it looks like the person's otherwise stable, they're walking, talking, able to eat a sandwich. That's the usual way that people think about this. We can move them over really quickly and then do all the psychiatric evaluation there. You've got designated emergency psychiatric staff who are trained, and it's a different kind of environment where the usual emergency department can be disruptive, scary, frightening, a lot of uniformed personnel running around, confined space, noises, sirens, everything going on. We changed that into this calm, relaxing, home-like atmosphere where instead of people being cordoned off into little small spaces with a sitter, everybody's in a large room where you get to choose your own recliner and you just get to hang out. You can talk to everybody. The nurses are interspersed with you. If you want to go up and get something to eat or drink, you can do that. You can watch TV, you can read a book. It's a really nice, calm environment, but what's nice about it too, since it's one large room that everybody's in, everybody's under direct observation, it's ligature safe, so you don't have to worry about changing all of your ER design to make sure that these are safe units for people with psychiatric conditions. Instead, you can move people into this. And the other thing that's neat about it, sometimes people will say, oh my gosh, how can you put all these high acuity psych patients who are dangerous to others in a room like this? And we usually have to put those folks into restraints, and they're going to be dangerous, and they're going to be assaultive. Put them into this comfortable, relaxed, calming setting, and it's like magic. People calm down, their risk of becoming aggressive or agitated drops down like you wouldn't believe. So the average number of people going into restraints in these units is 1 or 2 out of every 1,000 patients. It just really mellows people out. You know, people go into the lobby of the Four Seasons Hotel, they're going to act differently than if they're in the main floor of the high security prison. And that's basically the difference. You change the environment, people respond to it. And what's also nice about that is that these units have shown that more than 80% of people who come in who we would have hospitalized in a traditional setup, these are people who are on involuntary psych holds, dangerous self or others, high acuity, schizophrenia, bipolar, depression, suicidal, aggressive, threatening. In less than 24 hours, 80% of them are usually able to go somewhere less restrictive, as we call it, than a hospital, and that usually means home or somewhere in the community. And what's really nice about that, even for the inpatient units, we always talk about how there's not enough inpatient beds. Well, what if we dropped 80% of the people going to those inpatient beds? Maybe all of a sudden there's enough inpatient beds, but it's even good for the inpatient units because we're not just sending everybody there, some of whom didn't need to be there in the first place and are complicated, lots of paperwork, they don't even get reimbursement for them, there's these revolving door turnaround. No, instead, the only people who are coming are the ones who really have no alternative, who need a few days in the hospital, and they arrive there with a full day of treatment, documentation, and evaluation by a psychiatrist, and understanding that they're going to be safe and work well in this environment. So it's a win-win-win across the board. And so what this design is, as I mentioned, you have one large room where everybody's in, people choose their own recliner, and there's 80 square feet per patient, but pretty much 36 square feet per recliner. And here's some of the different ones that exist around the USA right now, and these have just amazing studies and metrics coming out of these places. Different places, the one at like the top left, for example, is the University of Iowa, a major academic medical center. Far right is a community hospital in Los Angeles. The lower left is a small hospital in Santa Barbara. Here's one in Billings, Montana. You've got them in Oregon, you've got them in Illinois, you've got them in Minnesota, in Southern California. Right now there seems to be, I think we're getting to close to like 75 of them across the country. Multidisciplinary, the key thing about it is that every patient is going to get evaluated by a psychiatrist within 1 hour after arrival. That's a key reason that so many people are able to go home in less than 24 hours. So much of mental health emergencies traditionally has been a lot of people see somebody and then finally a psychiatrist will see them several hours later. We put the psychiatrist to the front of the line. Main reason, most of these folks need diagnoses and they need to be started on meds in the great majority of cases. If you start those meds appropriately at the right doses and you have interventions and constant reevaluation in these units, you're going to find an amazing number of people stabilized and we're able to get them home or somewhere less restrictive. Yeah, here's the slide showing these are all the places that have been opening Empath units across the USA. As you can see, there's a number of different sites, pretty much coast to coast at this point, and it's just been really amazing, and I know of about 15 to 20 that are in the developmental stages right now as well. Here's some real quick numbers. Hospital in Southern California, averaging right now, and they just had finished their first year. They had 3,700 emergency 5150 patients, they're called in California, involuntary psych patients. 81% went home in less than 24 hours, average length of stay 16 hours, and only 2 out of every 1,000 patients ended up in physical restraints. Only 1 out of every 1,000 patients had any kind of involvement with an injury, patient or staff. Here's, like I mentioned, University of Iowa, same kind of metrics, 75% discharge. But here's some other really neat things. 90% decrease in the number of patient hours boarding in the general ED. What did that mean for all the patients in the ED? They're left without being seen for general emergency medicine patients. Just overall, everybody coming into their general ED, their LDWS dropped by 60% because they were moving all these psych patients out of that ED into the more appropriate location, giving them better care, which was actually more cost effective, and that opened up more beds in the general emergency department for the non-psychiatric emergencies. So even doing better for the emergency psych patients actually ends up being a win for the general non-emergency psychiatric patients. Here's some quotes from some politicians in the state that said how great it was. Here's Billings, Montana, just to show that this can work in a rural environment as well. Same kind of metrics once again. And one of the things that people often ask that comes up with these units is like, oh, if you're getting all these people better and getting them out in less than 24 hours, doesn't that mean they're just going to be coming back? Actually, by creating this unit, they reduce the recidivism for psych patients to the emergency department by over 50%. Because they're actually getting them the right kind of care and getting them plugged into systems It's not just a revolving door. It's actually just moving up the timelines, eliminating the delays, getting people the help they need, where they need, and when they need it. Same kind of thing, major psychiatric unit in Portland, where there's a hub and spoke thing where all the psychiatric emergency patients come from 3 counties, the greater metropolitan area. ERs, the ambulances can come directly straight from the field to this center. Police can bring people directly there, but they can also take transfers from every single hospital in the metropolitan area. And even with that, they're averaging 80% of these folks being discharged in less than 24 hours, dramatic reductions in the boarding hours of all the hospitals in the area. So there's reimbursement that's available for these through Medicare, Medicaid, and private. Unfortunately, the biggest issue right now is that it's inconsistent from state to state, and we've been trying to work on a national level through ACEP and some of their advisory and legislative committees to try to really work on this, because we realize this is the solution for boarding. We can actually solve boarding. We can eliminate psych boarding by doing these, and it's so cost effective because a usual visit to a psychiatric obs unit, like an Empath unit, is going to cost about $1,000 to $1,500. And if we're going to eliminate the need for inpatient admission in 80% of psychiatric patients who would have been hospitalized otherwise, usually a psychiatric hospitalization is about $10,000. So if you pay us $1,500 and we're going to avoid a hospitalization in 4 out of every 5 patients, that means for every $7,500 you give an Empath unit, they'll save a payer, whether it's Medicaid, Medicare, or private insurance, $40,000. It doesn't take long for that to go into the millions. That Billings, Montana unit, as small as that is, rural, that's the biggest hospital in Montana, but that's still, it's a pretty small state, small population. They just finished their year anniversary. They were able to document that they saved payers in that little rural setting over $2 million in the first year by delivering better care more promptly. It's just amazing, and it's something that really needs to be embraced across the country. So it's perfectly aligned with healthcare reform, improves access to care, timeliness to care, quality of care, location of care. You're getting people to see the right provider in the right location in the right amount of time for the right cost. It's patient-centric. It's really different than anything that's been done before. It's avoiding all these unnecessary hospitalizations and dramatically lowering overall costs. So it's really a win-win, and you could tell I'm kind of an endorser of it. Anyway, I made it in time for the next talk to come in, and I know it's the last part. I appreciate you all coming in, seeing this, and we're being recorded. So thank you all for your